of the mammographic pattern. So we can see here that there is a pattern where we have little round, oops, sorry. Oops, something down there. Sorry, let's see if we can find the talk. Not much success there. So down the bottom here, we have different, oops, no, it didn't work either. Okay, I'll just go back one slide. Down the bottom there you can see little round shapes, which are nodular densities, and they're the TDLUs, right? Can you see the diagrammatic representation there? The other thing we see on the mammogram are linear structures, and those linear structures are ducts or vessels or fibrous strands that are joining the tissue together. Then you can see white tissue, which is the background fibrous tissue, and radiolucent adipose tissue. Right, so those are the components of the breast that we can see on the mammogram and ultrasound. There are two patterns that we have at the moment for the development of breast disease, and one is what we call a high-grade or model, and the other is a lower-grade model. So most tumours fall into the low-grade model, which is that diagram at the top. And what we can see there is that you start off with a normal TDLU, and it starts to get changes such as hyperplasia, and from the hyperplasia it can move through to normal fibrocystic changes and then through to atypia, and that's when it starts to become a problem. So the ADH, I'm not sure if I'm brave enough to press this button now, but I'll try. Yep, okay. ADH, right, is the very start before malignancy, right, and then it can develop into ductal carcinoma in situ, which is where it's contained within the duct, and then it can move on to invasive carcinoma. And down here they show you the two models, right? One model is the common model, the low-grade model, and the other one is for a high-grade model. So the low-grade model is what we see most of the time. The TDLU develops into DCIS, and from DCIS, which is a low-grade DCIS or intermediate grade, we get what we call invasive carcinoma of no special type. We used to call it invasive ductal carcinoma, but that terminology is not used now in the latest version of naming. And then the other model is the one demonstrated down here, where the ductal carcinoma in situ is a higher grade, and when it develops into invasive carcinoma, the markers, the estrogen and progesterone markers and the HER2 markers are no longer positive, and that is the triple negative type of cancer, and that's the more aggressive type of cancer. And then we have a model in the middle where we have the HER2 positive cancers. So there are different cancers linked to different genetic problems, and we can see, for example, the BRCA1 cancers tend to be the triple negative cancers, right? A more aggressive form of cancer. Anyhow, we have a range of findings, both benign and malignant, and one of our problems is that there is quite a lot of overlap in the appearance of these different benign and malignant conditions. So, what are our imaging options? Well, it depends what we're doing, whether we're doing screening or diagnostic, and I know you're not doing screening much here in this country, but in Australia, we've had a screening program that the government pays for asymptomatic women to come for screening, and that's been there since 1990. And the other group we have is diagnostic patients who've got a problem. And I'm sure you're all working with diagnostic patients who've got some symptom. But the tests that we can use, the modalities that we can use are actually the same. Right? We have mammography. I might have done something terrible. Okay. It might be one slide too far ahead, but I'll just try one back. Yeah. So, the range of tests we can use, mammography, ultrasound. Now, mammography we can link together both 2D digital mammography and 3D digital mammography or digital breast tomosynthesis. And then there's ultrasound, which can be handheld or automated whole breast ultrasound. And then there's contrast mammography and contrast MRI. And I'm going to talk a little bit about test selection in a moment. So what tests we use is influenced by what we know about the clinical findings. And those test results are what we find also influence how we do our biopsies. But I think I just want to emphasise that the best outcome for the patient is when we put the results of the clinical findings and the imaging findings and the biopsy findings together to make an accurate diagnosis. So we call that the triple test. Now, not all tests are equally sensitive or specific. If we look at what's used worldwide, mammography and ultrasound are the most widely used, right? Because they're the commonest tests we have. But the main limitation of mammography, which I'm sure here in Asia you would all know, is mammographic breast density, which can hide cancers. Right? So it limits the sensitivity of mammography. Ultrasound, on the other hand, is a good test in dense breasts, but it has a problem, and that is the specificity. Right? It finds lots of little things that turn out not to be cancer. So we also have contrast-enhanced mammography, which, while it's been around for maybe 2 decades, has become much more popular in recent years, certainly in Australia. And it's more popular because it's not limited by breast density. It doesn't matter what the background mammographic density is, it actually is quite sensitive. So this test here, I just show you the outcomes here. If you look here, you can see that they found 5.4 cancers per 1,000 women when they were screening with mammography. They found a similar number when they screened with ultrasound. When they combined them together, they found more cancers, so about 7 cancers in every 1,000 women. And this is just a way of explaining how sensitive the tests are. Then if you look at what happened when they did MRI, they found twice as many cancers. Right? So it's a much more sensitive test. And all the literature would suggest that contrast-enhanced mammography has the same sensitivity as contrast MRI. Right? So that means that it's a very good test for us because it's often difficult to get access to MRI. It's a very expensive piece of equipment and it's often very busy with other types of tests. And you can see down here in the diagram why contrast studies work. Right? So this is the diagram that shows you that when with conventional imaging you have to wait, for example, on mammography and ultrasound till the tumour is big enough for us to see as a lump. Whereas if we go back to looking for contrast, we can go back to a time when the tumour, in fact, is only small, but the contrast, the leaky vessels that are associated with the tumour are already present. And we can see that on the contrast-enhanced mammography or the contrast-enhanced MRI. So the other thing I just want to mention, of course, is BI-RADS, and I'm sure you all know about BI-RADS, but it's just the American College system for looking at 3 components of the imaging. The first would be what's happening in the background tissue, right? The background composition. The second thing would be to describe features of a lesion, something you found. And the third thing would to be put it into an assessment category where you can make some decisions about how you want to manage the patient. Right? So those 3 components are important. And we can see here, the BI-RADS, we won't look at it in detail, but I'm sure you've all seen. It's available for mammography, ultrasound, MRI, and contrast mammography. And then we can look here at the categories, the assessment categories, and based on those assessment categories, 0 to 5, we can determine how we want to manage the patient. So it's a good system because it makes you think, we have to stop and put things into a category and make some decisions based on that. So the first thing they talk about is background tissue density. And why do we worry about that? Well, we have a range of findings that we could see, which are soft tissue lesions or calcifications or some combination of the two. Right? And that's what we're normally looking for. And they're affected by the background density. Background density, as you know, reflects the number of TDLUs in the breast. Right? So younger women who may be about to have children or lactate or whatever, they have lots of TDLUs in the premenopausal breast, and of course you get fewer as you age. So younger people's breasts are more dense than older women's breasts, but there's a wide range of density in any one age group. In Western societies, it's said that about 40% of women who are over 40 years of age have dense breasts. And that is, they have them in this A, B, C, D category, the C and D breasts. Right? So BI-RADS A, B, C, D is something that you can determine the density of the breast either visually or using software. And most of the time now we try to move to software because it's more reliable, more repeatable, whereas visual software or visual assessment is actually quite inaccurate. So I've mentioned there that it's largely genetically determined. Studies of twins have shown that about 60–70% of your breast density is determined by your genetics. And we know that there are risks attached with density. There are two big risks. The first risk is the likelihood of developing breast cancer. With increasing density, you have an increased risk of breast cancer, maybe about 5 times if you compare the lowest density with the highest density. But there's also another big risk, and that big risk is the risk of missing the cancer on the mammogram. And that's one reason why we like to use ultrasound. Right? Because in this study mentioned down the bottom here, you can see that the risk of interval cancer was about 18 times in the first 12 months. So what that means is, following a normal screening mammogram, people who had an AB breast density had a low risk of having a cancer, whereas people in the CD category had 18 times the risk of having a breast cancer found clinically, right, after a normal mammogram. So this really reflects the fact that it's hard for us to see the density of the cancer in a dense breast. So what are the findings? Well, coming back to what we're looking for, we've got soft tissue lesions, which might be masses or architectural distortions, or asymmetries, something different on the two sides. And we have calcifications, and we've often got a combination of the two. And then there are other things, like what's happening to the skin or the nipple or other places. The problem is that the benign lesions, like fibroadenomas or papillomas or things like that, can overlap in appearance with the malignant things, ductal carcinoma in situ or invasive carcinoma. And the most likely things to overlap as well, or likely things to overlap, are trauma and infection. Because trauma and infection break through normal tissue structures, and that confuses us in our diagnosis. So I want to show you some appearances now of what carcinomas look like. And we'll talk about the common type, invasive carcinoma, no special type. And we'll talk about invasive lobular carcinoma, which is the second most common type. And then the small groups of special types, mucins, etc. And then some DCIS. So invasive carcinoma of no special type is the common cancer we see. And the higher the grade, the more likely it is to be rounded, right? Because it's like a balloon. As it grows, the margins just go out in a balloon fashion that's very quick. And if it's growing slowly, then the body has some time to start to wall it off, and it forms these spicules around the margin. So lower grade tumours are more likely to be spiculated. It has a range of appearances, and all of these pictures here are of invasive carcinoma, no special type. But sometimes it's just a rather really fine tumour, sometimes it's rounded and irregular, sometimes it's more like a bit of an architectural distortion, so there's a range of appearances. So I want to show some examples so you can have a think yourself, right? So what about this case? Can you see the carcinoma? Now normally when we're comparing, when we're examining a mammogram, we try to compare the two sides. So it's important to work your way through a mammogram by looking at the two sides, right? And comparing. And we can see if we look at this level that there's a difference, and if we look at this level that there's a difference, right? So that tells us that there's a problem in that area, and when we look at it more closely, we can see that it's a spiculated mass. Right? Spiculated mass with these sort of appearances, pretty classic for invasive carcinoma, no special type. Here's another one. This lady's breast has been altered by surgery, but nonetheless it's got a very obvious little cancer. So a little cancer here that we can see here in the retroparenchymal fat, and here again in the retroparenchymal fat. It's just a ill-defined, rounded mass, irregular in shape. It's a classic little invasive carcinoma. And this one, if we compare the two sides, can you see it? Yeah. So what we can see with this particular case is that there's a difference in the retroareolar areas. On one side, it's the area is more dense, the tissue is more dense, and the nipple is more pulled in than on the other side. So this is the one that's a little more nebulous, a little harder to see because it's not a mass as such. It's an ill-defined sort of density with architectural change. So another feature that's important when you start to find smaller tumours is to start to look for multifocality and multicentricity. And it's a very common finding. So multifocality means that there are more than one, or there is more than one focus of tumour in that area, in that lobe. In the same quadrant is usually how we define it. Whereas multicentricity means that you have a tumour in two different parts of the breast. And why do we bother with this? Well, particularly if we're going to do conservative surgery, which is the norm in Australia, for example, then you would need to know whether there is tumour in another part of the breast. And it's quite common. So a study many years ago by Golden Holland showed that multicentricity or multifocality is very common. 60% of tumours have multifocality, only 40% don't. And that means that if you have conservative surgery, most of the time you need radiotherapy because you almost certainly will be leaving some tumour behind. Another thing is the amount of ductal carcinoma that's present, the amount of calcifications that are present, because that affects management. So here's an example. Just a patient with a tumour. You can see the tumour quite easily. And it's got lots of calcifications within it. So this is a combination of invasive tumour and ductal carcinoma inside tumour. That's a combination type tumour. Now, invasive lobular carcinoma has a different appearance from invasive ductal carcinoma, and that's to do with the biochemistry of the tumour, the E-coherent. So, in an invasive carcinoma of no special type, there is E-coherent receptors, and that means that the tumour cells tend to stick together. When you get invasive lobular carcinoma, they're missing that and the tumours start to go out in a different sort of pattern, and that affects what the imaging looks like. So this tumour is pumped, and this tumour has just little strands of cells going out into the tissue. So different pattern. Invasive carcinoma makes up about 75% of cancers. Invasive lobular carcinoma makes up about 15%, roughly. So invasive lobular carcinoma is a tumour that seems to be increasing, certainly in Western societies, and there are a few different subtypes. And we always have a bit of trouble with lobulus because of the fact that the cells are just infiltrating into the normal tissues, not forming a mass so much as just single cells. So when we look, for example, at this case where the patient has invasive lobular, it's a bit hard to tell how extensive the tumour is. If we look at this, she has a normal breast on the right side, and she has very extensive lobular carcinoma on the left side. All this area here. So it's more like an architectural distortion. The pattern is a bit mixed up when you compare the two sides. And so that makes it difficult to say where does the tumour start and where does the tumour end. So estimating size can be quite difficult. And when you do an ultrasound, it's still difficult, right? Because it tends to have this pattern on ultrasound, what we call a picket fence type pattern, a pattern where you have little areas of shadowing coming off tumour foci, but they're separated by bits in between. So where does the tumour begin and where does the tumour end? It's difficult to say. Right? So this is a problem with lobular carcinoma. And you can see in this particular case, she had a little round density here, which was an involved lymph node. So it's a difficult tumour, but it's important to try and make the distinction. Sometimes it forms in a way that's more mass-like this one. But yeah, here you can see it's mass-like, but it's still a bit nebulous around the margins. It's still a bit hard to say where it begins and ends. And when it comes to conservative surgery, which as I say is the norm in Australia, it's difficult to try and estimate the size accurately. There are some varieties, probably don't need to know too much about it, but for example, pleomorphic lobular carcinoma and pleomorphic lobular carcinoma in situ, which means it looks a little bit like the normal invasive carcinoma with DCIS because it often forms calcifications, as in this example here. Here, there are some calcifications that look like DCIS, but they're actually pleomorphic lobular carcinoma in situ. So it's a complicated pattern. There are other special types, and they look different on imaging, on mammography and ultrasound. So tubular is one that we find in screening programs. Little carcinomas like this that look relatively well differentiated with lots of tubular structures, and they're very good prognosis tumours, and they look like this, generally speaking, on a mammogram. Little round tumours with big bits around the edge. This is another one we find sometimes. This carcinoma can be confusing because it looks a bit benign. Can you see it there? So there's okay, this one is another tubular, right? So, but a tiny one, and difficult to see in amongst this dense tissue, right? And it's just a tiny cancer on ultrasound. Or this one here, which is a mucinous carcinoma, forming lots of mucin, and therefore looking rather mass-like. Right? And this is an example of it. Can you see the tumour there? This is a mucinous carcinoma. ultrasound here. If we look at it in a bit more detail on these 2D, 3D images and ultrasound, you can see that it's often relatively well defined. Medullary carcinoma is another one. Another rare tumour, but quite a good prognosis tumour usually in younger women. And it also often has a rather well-defined sort of shape. So this is typical, and what it has is many inflammatory cells around the margins. So it's from that body's own reaction to the tumour. So you don't have to worry too much about those benign types, other than those special types, other than to know that the appearances tend to overlap with benign structures. So I'm sure you've all seen millions of fibroadenomas, very common normal finding. But they can vary a bit and look a little bit like those tumours. And that's the difficulty sometimes. So fibroadenomas, as you know, should be parallel to the chest wall, they should be well defined, and we're going to talk more about this later. The other thing we might have that's benign is architectural distortions, and this is an example over here of a rather big, what we call radial scar or complex sclerosing lesion. It can be difficult to see on ultrasound, but they cause a disturbance of the architecture. And this disturbance of the architecture here is man-made. This is a surgical site. So let's just touch on calcifications for a few minutes. So calcifications are typically malignant in screening environments. They represent ductal carcinoma in situ, and of course that's generally speaking much more common in screening programs than it is in diagnostic settings. But there are lots of calcifications in benign structures, so this is our problem. The overlap is quite high. So how do we tell the difference between benign and malignant? Well, part of it is the variability. We expect a greater degree of variability of size, shape, and density in malignant calcifications than we do in benign ones. You need always to magnify the images to be able to make that differentiation accurately. And the thing about DCIS is when calcifications are in the dead tissue, aren't they? They're a dystrophic finding, and they are present inside, for example, this area of necrosis. This is the tumour, this is the necrosis, and the calcifications form in the necrosis. So you're looking at pleomorphic calcifications in that setting. And there are subtypes. We won't dwell too much on the subtypes, but there are different subtypes which have different prognoses, and we saw that early on, that certain subtypes tend to progress to the benign type of invasive tumour, and certain subtypes tend to progress to the more aggressive type of invasive tumour. And we see them in different ways. So when they first start off, they just look like a granular pattern, but as they coalesce, they can start to look linear, and they can even look like they're casting or taking up the shape of the duct. And maybe I'll just move on. So this is typical patterns of DCIS. This one over here is the granular pattern, crushed stone look, and this is the linear or casting sort of pattern. This is diagnostic of invasive ductal carcinoma in situ. Couldn't be anything else. Nothing else looks like that. And sometimes you can see the area of calcification on ultrasound. And if you see that area, it may look like this, just a disturbed architecture. Nothing very much. Might change in the epigenicity of the tissue. And that may be invasive, but it may actually just be the body's immune reaction. And so normally we would biopsy with ultrasound control in that particular situation and see whether or not there's evidence of invasion. But the morphology can be very difficult to differentiate. So these are just a few examples now of different cases of DCIS. This particular one's very obvious. here wasn't as obvious, right? So they become very obvious as they progress. This is ductal carcinoma inside you, again, pleomorphic, and you can see that around the outside there's this bit of density, body's immune response to the tumour. Again, this is another case of DCIS, but it's much less obvious in a sense, a little bit linear. So often they overlap, as you know, benign and malignant, because fibrocystic change can look very similar. And that's the dilemma, isn't it? And that's why we have mammo-guided vacuum-assisted biopsy to help us differentiate. Another DCIS. Another expensive DCIS. So what it tells us when you see DCIS this extensive is there's likely to be invasion, right? Likely to be some invasive disease. This is benign, but as you can see, it overlaps in appearance. So, in summary, there are models of development of carcinoma from just normal TDL use to hyperplasia, through to atypia, through to ductal carcinoma in situ, through to invasive malignancy. And there are different patterns that are associated with different genetic problems, and they have different appearances on the mammogram. So there's quite a range of appearances, and it's helpful for us to use the virus to try and categorize things a little more carefully, and that enables us to correlate the imaging and the histopathology. So thank you very much. That's where I wanted to finish. Thank you.
My presentation is very basic. After seeing the work that is being done in the department here, I think you all are doing a very high level of breast imaging. So it's going to be more a revision rather than learning anything new perhaps over the weekend, but hopefully the more we listen to the same thing again and again, the better we remember it. So I'll just get started. Ultrasound started off, a lot of the early work was done in Australia, so the groups who were involved had research laboratories. One of them was called Advanced Technology Laboratory, and their work, this is 1962, so very early ultrasound equipment. There was a scientist called George Kossoff, who was a pioneer in the field, along with many others working together. And they experimented with the scans on sheep. So the first patient, you can see the sheep is not very happy, stuck in an awkward position, had been the subject for early work. Ultrasound progressed quite quickly to become applicable in medicine for use on humans, though the equipment is still quite primitive, as you see here. This is a scan, again this is from a historic document that I've referenced. So they were using a mechanical type of scanner to look at the thyroid in the patient. There was diagnostic work trying to look at breast lesions in the early 70s in the Royal Prince Alfred Hospital, which is in Sydney. Of course, now you have high-tech modern equipment. It shows us a lot more than even we know. So we are also challenged to learn ultrasound anatomy because the equipment is showing us much more detail, and it's challenging us to use the technology as best possible. So where do we use sonography in assessing patients with breast problems? So of course, it tends to be broadly into categories. You can use ultrasound as the first line of assessment, and typically this is in the younger woman before the age of 40. In Australia, before they join the breast screening program, younger women tend to have an ultrasound first. Often the breast may be dense, and ultrasound is more suitable to do a comprehensive evaluation of both breast and the axilla. Of course, a person who presents with acute symptoms like pain or swelling, some warmth, redness. So, like Professor Raikard mentioned, if there's trauma, infection, these situations, ultrasound is often a good test to do. A mammogram can be very painful in a person like that, so you avoid mammogram, you do an ultrasound. Post-operative assessment also, again, similar situation, quite awkward, tender, painful breast, you really wouldn't want to use mammogram. And of course, the post-mastectomy assessment predominantly is with ultrasound. Similarly, during problems during pregnancy and lactation, where the breast can develop fairly acute issues and needs checking, it's a good modality. We've got to talk about ductal tomorrow, so nipple discharge and nipple retraction, you often need to interrogate the retroareolar region carefully for anything focal with ultrasound. Patients with breast implants, they again are amenable to initial check with ultrasound, and of course, the male patient who presents with symptoms in relation to the breast. And of course, it is then a complementary or a completion study together with the mammogram. So any symptomatic patient should receive a mammogram correlated with the ultrasound. So the two parts of the triple test, and then if you find something focal, you have to decide whether you're going to go on to the third part of the test, which is preferably some form of biopsy. We might, of course, in a breast screening situation, have to recall the patient based on a positive mammogram, and there will be a targeted ultrasound of the area of interest. It is crucial to assess the axilla so that you stage disease accurately before planning further management. It definitely has a role as a targeted study after mammogram or MRI, especially MRI has shown a focal abnormality, and we might try to find it so that we can both characterize it and also perhaps biopsy it without having to do an MR-guided biopsy, which are quite complex and difficult to perform. We clearly like to use ultrasound for its real-time ability to guide procedures, and there is perhaps some role of ultrasound being the primary method of assessing women with intense stress. The basics of sonography don't change where you apply them in the body, so obviously we are all familiar with the knobology of equipment, but it's something that you do need to keep considering every time. Be careful. I have a confession or disclaimer to make. I have borrowed extensively from the internet. This material is available for educational purposes from various bodies, including RSNA. And it's a good way of putting across the basics. So don't forget using the highest frequency you can get to examine the depth of the field of view. Use harmonics when required. Adjust your focal zone and adjust the gain as well. Basic scanning technique. We have sonographers who do the scans for us where we work in Australia, but here I understand you're doing all these scans yourself. So you'd have to have your own individual pattern to make sure you assess the breast in various positions so that the breast is spread out, reduced in depth. Remember to scan in orthogonal planes. So in the breast, it's probably better to do radial and anteradial scanning rather than longitudinal and transverse scanning like you would expect the anatomy to be in most cross-sectional imaging. I won't go to the anatomy, which we've already heard about, but suffice to say that when you have the patient supine for most ultrasound scans, the anatomy will be, broadly speaking, like this. So the more superficial band of tissue is fat. Below that is the glandular tissue, and then the retromammary fat lying on the pectoral musculature of the chest wall. The same anatomy is, of course, visible on ultrasound with fat, the glandular tissue, muscles, and then your ribs and the lung interface. Again, the same thing on an image, typical ultrasound image. The subcutaneous fat, which is variable of course in thickness, and glandular tissue itself, fibroglandular tissue, which again varies from person to person, and then the retromyographic fat plane. Something unusual about the breast fat is that it's relatively dark. Most of the fat, subcutaneous fat in the rest of the body will be relatively photogenic, but in the breast the fat is relatively dark. I'll yet to find a very adequate explanation for that, but it's an observation that we all make all the time. A dense breast again is a challenge on mammogram. So here you have someone with a Byrax deep, so extremely dense breast, and you can see that that breast is comprised primarily of fibroglandular tissue with less fat and no retromyographic fat at all. So it does give you, ultrasound does give you a look into that part of the breast where mammogram might give you a homogeneous density with no tissue differentiation. I mentioned harmonics, so this is just a case from the internet where they've used harmonics to highlight the borders of a particular lesion. So I'll just go back this one. So here there's a very subtle small lesion shown by the arrow there. Its borders and perhaps internal texture are not clearly defined, but with the use of harmonics you do get much more clarity. You can see the borders of the lesion better, you can recognize that there is something there, and then of course make a plan based on these features about what you want to do next. With some issues, we like to know the stiffness. I always suggest that our sonographers do this simple maneuver of Thermitis. So you just ask the patient to go something like the chants that you might have heard otherwise in temples. You just go loud, and the tissue will vibrate. So that's like Thermitis, and it can highlight an area which is not doing that. And it does help to differentiate borders of lesions, though of course the more current way of doing that, and it will come in, get much more established, is elastography. So elastography is still, I would say, in my practice, not being used extensively. I think some of the other faculty members might have different views, but it hasn't become routine clinical practice in the evaluation of a breast lesion. But I think it's something that will be applicable as we all get more familiar with the technique, the technology, and it's validated in large trials. Broadly speaking, there is a visual sort of grading scale that has been suggested to assess the tissue stiffness relative to the structures around it. So is the stiff tissue comprising none of the lesion, part of the lesion, the central aspect of the lesion, circumscribed to the lesion, which is visible on BMO or regular ultrasound, or is it exceeding the borders of that lesion, or is there an unusual mixed pattern within it, which is supposed to be typical of a cyst? The other add-on that we want to use is Doppler. So obviously breast tumors are also hungry for blood, and neovascularity of the tumor is something that can be detected. Certainly MR with contrast and contrast enhanced mammogram are well established as ways of showing this, but just a basic ultrasound using the more sensitive methods of detecting internal flow can help show something as being solid with internal vascularity rather than just a cystic lesion, or a lymph node can show unusual vascularity, which is more worrying for pathology rather than just a reactive node. So I mentioned the low flow sensitivity of the newer modes of Doppler that we have available, and we can prove that something has got unusual tumor-type vascularity within it. We've heard about Byrax and grading, which helps us put disease within a certain scale, from benign to malignant, and putting that category at the end of the report is a useful way of communicating how worried you might think something is by its imaging features. the various groups within each modality are broadly aligned, and you want to use all the imaging available to you to decide what category to give that particular lesion. Just going to the basic descriptors from the BI-RADS 5th edition. So you find like there are the category, so the benign or typically benign findings in cysts of various types, but as the cyst appears more complex or more complicated or has certain solid components, then it's going to go up in the BI-RADS ladder and become more and more worrying. There are some issues with ultrasound itself inherently, because some things which are almost isoechoic to the surrounding tissue can appear like a discrete lesion. For example, entrapped fat can appear as if it's an ovoid focal mass surrounded by some fibrogranulate tissue, and the other way around, and you can have something which is a complex cyst but may simulate a mass lesion. Again, if you use Paradoppler and show there's internal vascularity, but we need more solidity. Of course, there are some other straightforward ways of making sure what you're dealing with. You can always put in a new aspect to content. So for masses, the descriptions are based on the shape, the margins, the orientation of the lesion, and helps us determine which area, which types of lesions are probably benign and which group, based on their combined features, are possibly malignant and suspicious and deserve biopsies. Calcifications is another of the features that we can detect even with ultrasound, or of course in combining the mammogram with an ultrasound of the same area for echogenic foci, which are increasingly well detected by the ultrasound machines and prove that there is some form of microcalcification within that particular mass. So just going into the descriptors again, so with shape, you want to describe that. It's oval, that's round, that's irregular. It's very straightforward, but often till you sit down and sort of think about it a bit and put all of these descriptors in one line, you may not be able to get to a diagnosis easily. Again, is this parallel to the surface and the underlying stroma or surrounding tissue, or is it sort of breaking through the barriers and is more taller than wide? So not parallel. Are the margins well defined, circumscribed? Are they indistinct? Is there some angularity? Is there small loculations? And of course, is it that classic spiculated soft tissue lesion with streaky bands going into the surrounding parenchyma? The internal ecotexture, we're talking about just clearly anechoic. Then the hyperechoic, not very common. Complex, cystic and solid. Isoechoic lesions, heterogeneous, and then the posterior features. So behind the lesion, what's happening to the ultrasound beam and the reflection. So here there is enhancement behind something which is usually mean cystic, but it can be there in some solid lesions. Here there is a distal beam attenuation, so there's a shadowing, and here there is a combination of the two. Typical lesions, so here you have a cyst, so it's shape-wise, it's oval, it seems to be wider and tall, so it's parallel. There's clear-cut distal or posterior enhancement. There is no internal vascularity. As I said, this other patient analysis has got a more lobulated margin, but yet it looks anechoic, and there was no internal or vertical flow. If the patient is symptomatic or there is a doubt what we want to do next, you can always run some guided aspiration and send out some people for testing. cyst. So this is a person, elderly lady, who came with an ultrasound finding after a routine check with a complex cyst, had some unusual debris or some material within it. The core biopsy appeared to collapse the cyst partly, but the histology came back with a low-grade DCIS. Another patient with a tiny lesion. This was a general screening assessment of the breast before planning breast reduction surgery. There was a small anechoic lesion, possibly cystic, to be characterized as only 3 millimeters in size. You aspirate, it disappears. You're happy, you're comfortable that you're doing something purely cystic. Of course, anything that you aspirate, you should send away for cytology at the very least, because it's a fluid sample. Another example of cystic benign pattern changes is just cutaneous, sort of a lobulated, dilated segment of gut with no intraductal debris content. We use Doppler as well to check for any vascularity around the area in the wall as well. So there's a recent article in Radiographics which you can look at with some sort of a complicated long algorithm to determine which cysts need more assessment and how you categorize them in the various virus groups. It's got plenty of examples and some suggestions about how to manage these kind of cases. These are a group of different patients with typically benign findings, I suppose. So it's very common to see subareolar bacteria, especially in the older woman. And the other finding that we often see is this slightly echogenic but well circumscribed oval lesion in subcutaneous fat, some sort of lipoma. Definitely doesn't need any more imaging or follow-up or biopsy. It's not uncommon to have dermal, so skin-associated lesions which patients might present with a lump, often may be painful, and on ultrasound you can see that it's a subdermal cystic, often complex cystic lesion, some form of epidermal inclusion cyst. And all of these things are easily diagnosed with ultrasound, and we don't have to then worry about them further. We talked about the application in post-operative situations. So patients post-mastectomy can have very long-term anechoic fluid collections in the mastectomy bed, some form of seroma. When you scan along the long axis of the scar and then 90 degrees to that, you can see the orientation and shape of this anechoic space. It's a typical mastectomy bed seroma. Again, these will not need any more imaging or intervention at that point in time. Ultrasound is the best way to check that anti-adjust wall, and it's part of the surveillance when patients come for follow-ups. Post-mastectomy, they'll have an ultrasound of that anti-adjust wall and the same axilla, along with the other breast reports. So here's another patient with a small, possibly cystic lesion, but it appears like a cluster of microcysts, and with a history of previous breast cancer for which wide localization was done. On a routine surveillance, we found this finding, this area of change, not visible on mammogram, and because of the history, you're sort of dealing with a higher risk, and ultrasound guided biopsy showed this to be a small area of invasive carcinoma. Now we're going to the more frankly abnormal categories, so the BI-RADS 4 or 5. So a lady who's only 41 years old presents symptomatically with a lump. On the mammogram, there's a large lobulated mass density with some internal pleomorphic calcification, which appears to have a band of density extending towards the nipple. There's a second mass lesion, again irregular shape with some margin circulation and some internal calcification, and then you have this retromammary fat, circumscribed oval density, which would be in the right location for a axillary tail or intramammary lymph node, which is unusually dense. The ultrasound of the main symptomatic mass shows this extensive, bulky, lobulated hypoechoic lesion, again showing this band extending towards the subaerial region of the nipple and extending out into the rest parenchyma. So, frankly, unusual mass lesion likely to be cancer, and on color Doppler you can see this bizarre internal vascularity within the solid components of the mass. Checking further, the second lesion which was visible on the mammogram is also seen at 10 o'clock, showing some of the internal microcalcific foci, and the lymph node that you can see on the mammogram is also visible as a unusual lump, taller than wide node, doesn't have its normal architecture. So this is clearly Leydig's 5 category, and we biopsied all 3 areas to try to prove what the actual diagnosis is and provide some form of detailed staging to the surgical team. Just to reiterate that you can see microcalcifications on the ultrasound in several cases now. Just another example where the mass density of internal calcifications on the mammogram views is also visible with ultrasound. I won't go into that anymore now, hopefully. So, the other sort of situation is a patient with a almost incidental finding. So, an elderly lady had a fall, and after the fall had some tenderness, examined herself and felt there was something there. There was a lump presented to the family doctor, came in for a mammogram ultrasound. Mammogram showed the patient questionnaire sheet has a drawing in which they can show their area of concern, and this was the area that she indicated. There was a corresponding mass density seen on the mammogram. The ultrasound showed this as well, and this lesion on ultrasound was a relatively isoechoic, bulky lesion with marginal lobulations, certainly solid, and proved to be a mucinous carcinoma, so one of the less common cancers, also appearing on imaging in a very way, not like the classic invasive carcinoma or the NOS category. Another lady with a incidental sort of screening mammogram ultrasound situation where there's a small circumscribed density visible in the right breast. On ultrasound, it could be really anything. Is this a paradenoma? Is it a complex cyst? Is it a solid lesion? Again, just using the tremetis, we find that the lesion itself certainly doesn't have any tissue vibration. It doesn't really help us to characterize it any further. But this is the sort of situation that we certainly want to go ahead and do a prolonged biopsy. Just coming to the axilla, because the breast has extensive lymphatic drainage, the assessment of the axilla is important, and the landmark to use during scanning of the axilla is the pectoralis minor muscle, which is sort of sandwiched between the major and the latissimus dorsi, and you kind of trying to assess the axilla in a quadrant pattern. So upper inner, or you can say anteromedial, posteromedial, anterolateral, posterolateral, and because your lymphatic drainage can go in many directions, but primarily you go up into the axillary area. the challenge we often have is to detect spread of disease in the internal mammary nodes. But most commonly, we'll be looking for the axillary nodes of ultrasound. And the suggestion is that you are trying to group them according to level. The levels are separated by the landmark of the pectoralis minor muscle. And level 1 nodes lie inferior and slightly lateral. The level 2 nodes are sandwiched between the major and the minor, and the level 3 nodes are more medial to the pectoralis minor muscle belly itself. When you are scanning and your anatomy is aligned like this, so the pectoralis minor muscle belly passing across obliquely almost parallel to the ribs, and you have the level 1 muscles just lateral, the level 1 nodes, the level 2 nodes lying above the belly, and the level 3 nodes further medial. The lymph node disease basically is the malignant cells are entering the node from the periphery into the cortex, which is normally hypoechoic and thin. As those malignant cells take residence in the cortex, they start growing, attracting their own blood supply, and making the cortex thicker. Often it might be an eccentric thickening of the cortex. Sometimes it is quite extensive, and the hilum is gradually getting effaced. So you go from normal to quite diffusely thickened cortex and eccentric nodular thickening of the cortex, or almost complete replacement of the node with the hilum becoming very small. It is useful to also check for vascularity with color Doppler, because malignant vascularity is usually coming into the cortex from the periphery, and there is no loss of the normal hilar vascular pattern of the lymph node. So here is your normal node, which you've all seen before, and versus a clearly abnormal node with a lot of lobulated hypoechoic cortical thickening and displaced distorted fat hilum. The intramammary nodes are focal usually, like on the mammogram you will see something which is usually quite typical, but it's quite satisfying to be able to correlate that with ultrasound and find the small intramammary nodes, so just 4 millimeters, but it has the classic appearance of a node anywhere else, with a smooth border, a hypoechoic cortex, and a well-preserved fat hilum, and often with the high sensitivity Doppler technique, you can show the hilar vascularity as well. Moving on to the other application of ultrasound is for breast implants. So implants over time are prone to develop complications. The most worrying one would be neoplasm, but the most common one is some form of rupture, whether it's intracapsular or extracapsular, and certainly ultrasound is a very good way of checking for this problem. So there you have a person with a breast implant, and around the margin of the implant there is this unusual broad band of hyperechoic material which has a distal sort of shadowing. It's called a snowstorm appearance, and the same material could be tracked into the axillary lymph nodes, which appear replaced by that silicon. I mean, once you see it, you recognize this very easily. I just want to also talk a little bit about the male breast. So men have some amount of breast tissue. Of course, it doesn't give us trouble till it starts growing for whatever reason. And typically we see patients with a unilateral symptom of breast swelling or something in the region of the areola, and that could be either gynecomastia or it could be cancer. You really don't know, but clinically, breast cancer in the male breast will present almost the same way, maybe a bit more firm or hard to feel. I think ultrasound does help us. So here we have a younger male with unilateral symptoms of pain and swelling near the right nipple. On ultrasound, there is clearly a corresponding area of increase in the bulk of the retroareolar tissue, which appears hypoechoic, but there is no asymmetry, there is no focal abnormality, there is no increased vascularity, and on examination, usually that would not be hard or feel nodular. And of course, it's good to compare, like in anything else in radiology, use the other side, and this is a unilateral finding, quite typical for gynecomastia. In contrast, this is another person, 54-year-old male, who came with similar symptoms, having noticed a lump in the breast for a few weeks. Ultrasound shows some sort of eccentric, asymmetric thickening of this tissue in the retroareolar region, perhaps some echogenic foci, and this was worrying that it's not gynecomastia, so we would want to proceed with doing a mammogram, and you can often get decent quality mammogram in a male patient, so probably only the MLO view, and you can see the asymmetry is quite apparent here in the same gentleman. So he's got quite a bit of nipple retraction, thickening of the areola, normal band in the retroareolar region, and the mass density itself. So this was biopsy and shown to be invasive carcinoma. We mentioned about pregnancy and lactation, but even without pregnancy or lactation, the breast can become acutely inflamed, and here also the benefit of ultrasound is to be able to see the area of symptoms without having to have a painful test done, and typically most regions which are inflamed in the breast, just like in other parts of the body, become quite echogenic. It's a very diffuse abnormality, and don't forget to compare with the normal asymptomatic part of the same breast or with the opposite breast to highlight this appearance and the difference between the abnormal and the normal side. And another person who had an acute presentation in the area of abnormal diffuse hyperechoic changes. There was a focal area which had more fluid content. In real time, this echogenic material, low level echoes could be seen to be moving, so we were worried about an abscess had formed. Again, ultrasound guided aspiration proved that it was purulent. You can send the material away for culture to adjust the appropriate antibiotic treatment. Often decompressing the abscess helps with the recovery as well. So ultrasound is very useful as the first line of imaging in these cases. So the changes in the breast during pregnancy are in a way confusing, because the acute presentation in breast in a pregnant lady with the breast symptom can be obscured, I guess, by the normal appearance of the breast during pregnancy and during lactation. Just something I want to highlight. So using or looking at the area of clinical concern where there may be some pain or warmth, and comparing it with the other parts of the breast is a good way of localizing and confirming that there's something abnormal there. So we talked about complementary ultrasound. So I think in patients with MRI, doing a targeted second look ultrasound is very useful, and it does help us localize pathology, which then can help us decide how best to sample it and prove what it is due to. about the 6th edition of BIRADS, which we are eagerly awaiting, but I found this resource mentioning what is expected to come. I think we are mostly using these features already in our day-to-day practice. So one reflection of the immune reaction, the body reaction, as well as the invasion of carcinoma into the surrounding tissues, this band of echogenic tissues surrounding some types of malignant lesions, and this echogenic rind, as it's described, is a good way of trying to judge that it could be malignant, and it's sort of indirectly reflected in the strain elastography findings as well, where that echogenic rind also shows increased stiffness, as does the visible hypoechoic solid mass. The other thing that we again have a presentation on tomorrow is this concept of a non-mass-like lesion, which from what I see, BIRADS would like us to then describe as being either hypoechoic, which means echogenicity, hyperechoic, isoechoic, and then give its orientation, whether it's parallel or anti-parallel. These are the cases which are clearly very, very challenging to even detect. So the first challenge is to detect them, then to describe them, and then to characterize them with some form of biopsy. So hopefully we are probably using more advanced levels of imaging already to try and decide what the disease is, but it's perceiving and finding it, which is still quite difficult. I won't go into this, which I think we'll cover quite a bit in detail. And we've already heard about invasive nodular carcinoma, so I think I'll stop there and say Taman, is it? Taman?